Hello, I'm Dr. Suddhasattwa Sen, Senior Consultant, Surgical Gastroenterology, GI Oncology, Laparoscopy and Liver Transplant, presently associated with AMRI Dhakuria Hospitals, Ashok Nursing Home in Jodhpur Park and KDQ Center being my chamber. I was a former Senior Consultant with the Fortis Group of Hospitals, Director of Medica and Apollo Group of Hospitals. Stomach is basically the organ which we all know is the food passage. It is the one where the food goes from the mouth, it goes down the esophagus and holds in the stomach. That is the meal function, where the food is broken down into smaller pieces and then it is helpful for digestion. It secretes acid. Now, one of the most difficult situations of a stomach cancer, and which is a major issue in today's world, is stomach cancer. Now, it can be in the proximal, that is the beginning part of the stomach, in the mid part or in the distal part. There are many types of tumor which is there, but when we speak of cancer, we normally speak of adenocarcinoma. Now, the reason for stomach cancer, it is very high in Japan. So, the reasons have been seen as smoked fish and nitrosamines in food, alcohol, smoking, some hereditary conditions, some genetically determined conditions. There are a lot of things which are connected to formation of a stomach cancer. Now, the stomach cancer patients would present in varied ways. Mostly it can present simply with weight loss, loss of appetite and unexplained anemia. That is, your hemoglobin levels are very less. There is chronic bleeding from an ulcer. Two ways it can present: with a very ugly looking ulcer in an endoscopy. It can present with some sort of a gastric outlet obstruction, that it forms towards the outlet of the food passage. It blocks the passage and giving rise to gastric outlet obstruction. It can also present with spread, that is metastasis, or the local organ invasion. That it has gone to the pancreas, it has gone into the colon, it has gone to the other parts, so things like that. What we do is we would do an endoscopy and a biopsy. A biopsy would tell us the diagnosis. Sometimes a re-biopsy may be needed because not all places of biopsy may have the cancer cells. We would stage the disease based on a CT scan, sometimes PET scans, sometimes other endo-ultrasound and other tests, or an MRI. Once we have staged the disease and we know it is localized to the stomach, it has not spread to the surrounding organs, we can go for a surgery, either open or by laparoscopy, and take out a part of the stomach, the entire drainage basin, that is wherever the cancer can spread according to the lymph nodes. Usually they spread along the blood vessels which supply that organ or that region of that organ. So this is something called a D2 gastrectomy. We would chop off a major part of the stomach. Sometimes we would have to, depending on the location, size of the tumor, we may have to take out the entire stomach, which is called a D2 radical total gastrectomy. So a gastrectomy can be for the distal part, that is the part that is farther away, or for the proximal part which is near to the esophagus. Based on whatever we have taken out, we would have to reconstruct so that the patient can eat food. Ultimately, that's the target, through his mouth, and then have a digestion system. So the reconstruction usually is with a food passage called a gastrojejunostomy. Some people would do a gastroduodenostomy. Both are equally okay if the hands and the results in individual hand would decide the fate. Majority would do a gastrojejunostomy. Once again, we may put in a feeding tube through the jejunum for the early feeding of the patients, because these patients would be allowed, like for any upper GI surgery, we would allow food only after 4 to 5 days for the things to heal up, because if they don't heal, there would be a leak inside the abdomen, which is very problematic, can lead to second operation, can lead to even infection and death. Now, in stomach cancer, many of them would require post-operative chemoradiotherapy depending on the biopsy and the staging. Some of them which are initially inoperable, which we call the locally or regionally advanced, we would give a neoadjuvant chemoradiotherapy, downstage the disease, shrink the tumor, make it operable, and then go in and do an operation.